Hello everyone, I am Dr. Madhavan, second year junior resident in the Department of Radio Diagnosis at AIIMS Bibinagar, Hyderabad. Today I am going to present a learning case. 5-year-old male child was brought by their parents to the pediatric surgery department in view of shortness of breath. Outside X-ray and CT scan were done in this patient. So it is a frontal chest radiograph PA view of immature skeleton showing a well-defined, rounded, homogeneous radio opacity involving the left mid and lower zone of the lung field abutting the left lateral chest wall. There is no evidence of mass effect in the form of mediastinal shift, no calcification or air lucencies within the radio opacity, no pleural effusion in the form of maintained costophrenic and cardiophrenic angles, no obscuration of the cardiac margins, and no evidence of pleural thickening also on the sides. So the child underwent CT scan for the same. So these are the selected axial cut section of lung parenchymal windows showing a fluid attenuation lesion, a rounded oval fluid attenuation lesion with thin, smooth, hyperintense wall. It is abutting the left lateral chest wall. There is no evidence of communication with the bronchial cavity, no air fluid level, no fat or calcified component of the lesion. So it is the coronal reformatted soft tissue window, mediastinal window. It is showing the lesion abutting the left lateral chest wall, no evidence of communication with the bronchus, and there is no changes of lung parenchyma surrounding in the form of atelectasis or bronchiectatic changes. There is nothing is there. And these are the axial soft tissue windows showing no evidence of mediastinal lymphadenopathy. So considering these findings, so our differential diagnosis will be a first possibility is a pulmonary hydrated cyst. The second possibility is a pulmonary bronchogenic cyst. Third will be metastasis. It is very rare, least likely because these on the chest X-ray, as we see, the overlying rib appears normal. So no evidence of rib and overlying rib destruction or erosion. No evidence of widening of the intercostal spaces, suggesting that this is the metastasis appearing least likely. So pulmonary hydrated cyst, second is pulmonary bronchogenic cyst. So there will be two types of bronchogenic cyst. One is mediastinal, another one is pulmonary. So most common will be the mediastinal bronchogenic cyst, in which the subcranial mediastinum is the most common location. If it come to pulmonary bronchogenic cyst, the most common location will be the medial aspect, the lower lobe of the lung, and pulmonary hydrated cyst. So the patient underwent surgery in our pediatric surgery department. So it is showing, it is an intraoperative picture of the same child. So it is showing a white glistening membrane over the cyst. So considering these findings, so histopathological analysis also showed it is a hydrated cyst. So coming to a small discussion about the pulmonary hydrated cyst. So Echinococcus granulosus is responsible for most of the cases. So it will come under tapeworm chest wound. So intermediate host will be the domestic farm animals like sheep, horses. So where the asexual life cycle of the parasite is going to happen. Definitive host will be canines like foxes, dogs, everyone. So where the sexual life cycle of the parasite is going to happen. The most common site is the liver, followed by the lung parenchyma, where there will be unifocal or there will be multiple hydrated cyst will be in both liver and lung parenchyma. They grow slowly. They do not calcify in the pulmonary. They do not calcify in the lung. Why means because they show, because of gross expansion, lung is going to expand more, so there is no phase of healing in the lung parenchyma. That's why there is no calcification. So complication will be either it get infected or it get ruptured. They form anaphylactic shock like presentation or pneumothorax. If they communicate with the bronchus and the pleural cavity, it may form bronchopleural fistula. The giant hydrated will be the size more than 10 centimeters. So this is the life cycle of the parasite. So the infection of the definitive host by ingestion of cyst in the organ of the intermediate host. So the adult tapeworm reside in the small intestine of the definitive host. The gravid proclotis are shed in the host feces and they got encysted, and the encysted hydrated will be eaten by either intermediate host or by man. Man is the accidental intermediate host, and the life cycle continues so as on. So this is a histological pattern. So there will be three coverings of the hydrated cyst: pericyst, ectocyst, endocyst. Within the tortoises we can able to see the pericyst is formed by the outer fibrotic capsule, which is formed by the host system, host immune response, due to host immune response. Ectocyst, it is a middle membrane. It is responsible for the nutrient delivery into the endocyst. The endocyst contain brood capsule and the scoliosis, developing scoliosis through which the daughter hydrated cyst arises. So radiological manifestations of the primary hydrated cyst, it may be uncomplicated, complicated. So in our case, it is uncomplicated. The cyst showing smooth walls. In our case, then daughter cyst calcification. The complicated will be ruptured or infected. If it is infected, we can see ring enhancement in case of contrast studies, air bubble sign, air fluid level. If it is ruptured, completed or contained. Contained rupture, air crescent sign, inverse crescent sign, air bubble sign. Completed rupture, combo sign, world sign, water lily sign, rising sun sign, mass within the cavity sign in the form of intercarcerated membrane sign, dry cyst sign. Then associated will be atelectasis, bronchiectasis, mediastinal lymphadenopathy, pleural thickening, pleural effusion. So we are not able to see any of the features in our case because the surrounding lung parenchyma, everything appear normal in our case. So these are my references. Thank you. Stay tuned for the more videos. Thank you.